So I'm David Adams. I'm one of the epilepsy fellows here at Children's Hospital of Orange County, as well as UCI. I wanted to give a little bit of a conversation, just a talk about some of our rescue medications, as well as a very important topic, status epilepticus, or our prolonged seizures, if you will. Just as a little bit of a background, one of the most common questions that we are asked in clinic is, are seizures harmful? And that definitely depends on a variety of factors, and we normally will phrase it depends on how long it goes on for, the age of the patient, and really kind of what the cause of the seizure is as well. In terms of some other things as well, in terms of like their respiratory status, definitely if that is in any way impaired by the seizure, that does escalate the seizure to being something that is more concerning as well. And just kind of some of that does interfere with or impact how we treat the seizures as well, and how we adjust our medications and how we respond to them in the acute setting. In terms of status epilepticus, we now chosen to define that as any seizure that goes on greater than 5 minutes, particularly if it requires medications to stop it, or if they have multiple seizures without kind of return back to their normal self. This is much more of like what we call an operational definition. Traditionally, it was termed that any seizure that lasted for longer than 30 minutes was considered status. But what we found is that the seizures that do last for at least 5 minutes, they tend to go on to last for 30 minutes. And it makes more sense to make those interventions earlier when we can, maybe with less medications rather than waiting for that 30-minute mark. And that 30-minute mark is really when we talk about, there is really some degree of irreversible damage. So definitely important to make that intervention before we reach that point rather than waiting for that to happen. As I mentioned too, oftentimes when we stop seizures earlier, we don't necessarily need as much medication, and that makes the recovery period much faster, kind of get you guys back to where you want to be, back home or staying home in some situations as well. So what I have just in front on my slides is just kind of our guideline for managing what we call status epilepticus, or these prolonged seizures, usually more in the hospital setting, but there are some pieces of this that also go outside of the hospital. And this is just our clinical guidelines. I know that there's a variety of different guidelines for different hospitals, and there's some modifications to that, and I'll kind of walk you guys through it. And kind of some places where we might have some different things, but overall, there is a structure that is pretty similar throughout most hospitals and hospital to hospital, and I'll kind of highlight those areas as well. In general, I do feel that it is important for us to at least talk about some of these things so that we can all kind of understand what the plan is and kind of work our way through step by step. And with everything that it is in much more of an acute situation, it can be harder to understand what's going on when everything is much more anxious and kind of acute at that time. So kind of having a little bit of a guideline of what's going on and maybe knowing some of these steps beforehand can hopefully put everyone at ease if you do find yourself in this situation. And also just, kind of understanding this pathway so that nothing really becomes a surprise if we get to that point. But obviously, our hope is that we stop things earlier in this process rather than later. So I mentioned most places do have a similar guideline, and oftentimes we find ourselves modifying that, sometimes based on the story, sometimes based on the individual patient. Sometimes it's really just kind of what's available in that hospital. And I think that in terms of some of these different checkpoints, it is very much based on time. So definitely, every 5 minutes where we do have a seizure kind of going on, that is kind of another chance for us to make a checkpoint and just kind of think about what those next steps are going to be. Might order different medications, or assess if something is working, assess for other factors as well. So the setting of where a seizure occurs is probably one of the most important things as well. So as I mentioned, our hospital guidelines are designed really more so for the emergency room or something were to happen within the hospital. But normally when we talk about seizures, they often begin at home, at school. You might even notice some things or seizures kind of come and go. Something might start in the middle of, you know, a ride to the ambulance as well. So oftentimes you'll see that we come up with plans just in case this happens. Sometimes it is with the school, we come up with a seizure action plan, which is kind of what we term a lot of these things. And that is definitely personalized to each individual patient, but there are some parts that might be similar across different patients. But the basics are still kind of there, and it's kind of more of, again, a structure to kind of guide us in that particular time frame, that situation, that clinical setting. So our first steps are usually, or in general, most of our steps involve IV medications, definitely in the hospital setting. But then, you know, when we're not in the hospital, we have to have some alternatives to that. So we've created some, not necessarily we per se, but doctors as a whole, we've designed more medications to be given outside of the hospital for these emergency medication or emergency situations. So they can be given in those in home or in school. And sometimes also when you're traveling from place to place, it's also important to always have those things available. Assisted care is definitely an important aspect of trying to stop seizures as well. And I do recommend that, you know, for everybody in the audience, as well as just in general, just kind of going over the situation with your doctor, whoever knows the patient best. So family and doctors kind of combining to come up with this plan is definitely helpful. Knowing the medications that, you know, the patient is on, if it's a new diagnosis, you may not always have that. If this is the first presentation, that may not also be available. But, you know, knowing the medications, kind of having everything listed, knowing if you're running low on the medications, getting refills and everything appropriately, so that we don't run out of those medications. Definitely having everything in place is number one, so that we don't have any triggers that we could have avoided by missing medications or running out or anything else like that. So the beginning of a seizure, I think this goes really for any seizure. It's really important to make sure that the child or young adult is safe. Make sure that, you know, they're in a place where they can't hurt themselves. We normally will recommend that we lower them to the ground or to a bed, put them on their side just in case there is any vomiting, any drooling, that there's nothing that they can choke on. We don't recommend putting anything in their mouth. I know that's something that was very classically done in the past in terms of like doing spoons and stuff like that, but really anything that goes in the mouth is a potential for them to choke on, and it's also, you know, in some situations for them to like bite through it, and so they're usually those type of processes cause more harm than good. So we really just recommend just kind of making sure they're in a safe place. You know, and very hard sometimes too, but just trying to make sure that we can also just note like why is, you know, take a message or note why this might be happening. Some people may even have a little bit of a warning before they have a seizure, so we call that like an aura. Some people might know, you know, if my child doesn't get enough sleep, they're at increased risk for seizure, which is a very common thing as well. So just kind of having those things, you know, or if there's just, you know, some other feeling that they're sick or whatever, you know, higher chances for seizures to really occur. For a lot of people as well, they kind of become into a habit of this, definitely if seizures are happening more frequently, but trying to at least force yourself to at least take a note of how long something is going on to is also a very important step. Sometimes that time marker is just you calling for help, calling somebody on the phone, calling 911. That can still even be used as a time point, and you just have a record of how long you're on the phone call with them. Other times, I know that a lot of our families got to the point where they'll reflexively, you know, grab their phone, take a video, set a timer, mark something on their watch. That's really important too, just because in terms of the timing of our interventions, that does play a role. And when you're in that situation, things feel like they're going on probably for much longer than they actually are. In that situation, it's very easy to overestimate how long the seizure is occurring. So our interventions in general, we usually start, as mentioned, starting to give a medication around like that 5-minute mark. For some people, that might be modified a little bit, but in general, you know, kind of around that point in time is usually the first time we make an intervention. Most of our seizures do resolve on their own within the first 2 or 3 minutes, but for some people, it does go on. if you are in that hospital setting or in like if you have EMS personnel there, you'll definitely notice that they'll try to take a little bit of a history in terms of the medications and try to find some of those other causes that we mentioned that might provoke the seizure to happen. In other situations, this could be a sign of something, that the medications are no longer working when they were working before, and we might just have some changing or worsening of the epilepsy in and of itself. And then, as I mentioned, also for other people, it might be, because of some new experience as well. So it's definitely good to at least kind of get a little bit of a situational awareness of what's going on. In the hospital setting, we'll definitely take some blood work, medication levels, a lot of other laboratory markers in terms of infection, electrolytes, and things like that will also be drawn. And we'll also do some monitoring as well in terms of like the heart and respiratory status. Those will be checked intermittently throughout the entire process. So it's just also good to make note of those and make sure that nothing is getting more concerning as we go along. Our first line treatment from a medication standpoint is the class of medications we call benzodiazepines. So traditionally they've been given via IV, and there's a couple different forms of those medications. The most common 3 medications that you'll encounter are midazolam, brand name for that is Versed, lorazepam, you're about Ativan, or diazepam or Valium. They're all very similar. Same family medication. They have like slightly different times where they'll last in the body and the times when they might kick in, but we usually will give 1 dose, and then if they're not seeing a response within 5 minutes, we might give a second dose of that medication as well. Very important. Nowadays, as I mentioned, we're coming up with much more portable forms. So traditionally, we've had a rectal form, which is Diastat, that's diazepam. And that's been around for a long time and used quite frequently. And then we're also coming out with some new intranasal versions as well, which are relatively new. Did want to speak a little bit more on these rescue medications because they play such a big role in the home and in the school setting where we kind of intervene at the start. I know that sometimes it will take some time for emergency personnel to come for the patient as well as transport as well. So there's time is very much an important aspect. So intervening early is there's really very much the theme here. And I do think that it's also very important just not only just to think about them as being part of this process. So there is some overlap within our scheduled hospital policy or hospital protocol, but also just knowing that like those first 5-10 minutes is really, it's helpful, and in terms of preventing this from going on to becoming a much longer seizure. We might even be able to intervene in that home setting, and in some cases even be able to keep people at home for monitoring if we can get seizures to stop there. These medications really should be pretty close at hand. I normally recommend that if your child is going to school, that they talk about it with the school, keep it in their backpack. You go on vacation, you go on a trip, you go even out to the park or something like that, so it's always available just in case. And equally as important, really knowing how to use it. So I did want to go through some of that process as well with you guys. So this is something that this is in terms of the Diastat administration. This is something that a little card that will come within your kit. And I do encourage everybody to actually open up the kit. I know that it's something that, in general, we don't want to have to use, but just again, preparing yourself for a worst case situation, making sure that you feel comfortable so that things go smoothly in that process. Open up the kit, look at it, making sure that things are not expired, that the dosages are correct from time to time can also be useful, particularly for those who don't have to use it very often, that we might have to do some updates based on age and weight and things like that as well. So walking really through the Diastat the procedure, is again, as we mentioned before, we kind of make sure that our patients are on their side laying down. At that point, you can kind of get the kit ready. You don't necessarily have to wait till like the 5-minute mark to get the kit ready. You can kind of, once you realize that they're in a safe place, you can always go and get whatever your emergency medication and get that close at hand. For Diastat, because this is rectal, there is some lubrication just to make things as comfortable as possible, even though at this point in time, patients are generally at a point where they're losing consciousness when we're going on for this long. But just, again, just trying to making sure everything is appropriate. There is, essentially, this is a syringe, so it's already pre-measured. So that, I don't know if you guys can see my cursor, but there are little indicating kind of arrows from that picture number 3, just kind of showing the dosage. So some of these medications are adjusted to fit the patient's exact weight, and you don't have to worry about trying to like squeezing out too much or too little. Just, you know, it'll stop kind of when the appropriate dose is given. So you just pushes completely, and the pharmacists have already set that in place. So you don't have to worry about, you know, giving the wrong dosage with that. Once they're on their side, you know, just lubricating the device, rolling them over. You do have to open up the buttocks and kind of insert the plastic tip of the syringe. So if you've ever seen it, it is plastic. It's not a needle or any sort. So, but it is, what comes out is very much a gel substance, and so that has to be kept within the rectum during this point in time. And I know that kind of mentions here kind of also just to count to 3 as well, just to make sure that everything is situated and absorbed properly. And then again, noting the time, how long this is going on for. Definitely, if you know you're not really seeing that response at 5 minutes, even for people that it typically works, like, you know, if we're getting to that point, I would, you know, call for, you know, more emergent help at that point in time if you're not seeing that response that you want to see. You can also see within the kit itself that there's 2 syringes. So this is really designed for you to be able to give that repeat dosage if you need to. Kind of that initial prescription, oftentimes we'll give 1 to school and you keep 1 at home, and that's fine. You can always pick up, you know, a refill a few weeks later, and that way you guys have a full kit just in case if you need to go about it that way. You never really want to be without at least 1 syringe as well. So ideally it is really for, you know, if we have to give 2 dosages, but you always have a spare as well. So Diastat, I just bring this up just to kind of show you how it's broken down. But relative to the patient's age, the dosage is much higher. So everything is based on weight in pediatrics. And really some of the dosage at some point we stop increasing once we kind of get older. But for our smaller kids, it might feel like they're getting like a really big dosage, and sometimes their dosage may not actually change as they get older, just depending on their weight. Sometimes it may actually even go down, and just really don't be alarmed if that happens. Just know that everything is being calculated, and that dosage is relatively different based on their age and their weight. So that's really what I wanted to get out of this slide. So on to our nasal sprays. There's actually 2 different companies that are coming out or have come out with medications for this. And these are really designed to be, 1, in some situations more portable, but 2, you know, they were more initially designed for some of our older kids. So Nasalam was the first medication that came out in a nasal spray version. This is intranasal midazolam. So our Versat is the other brand name for the IV version. So this was initially approved for children 12 and older. And again, just as an alternative, I know that once we get to kids being about 12 years old, they tend to resemble more or less adult size at that point. So it can be harder to maneuver things in terms of giving the Diastat, and as well just trying to keep that, you know, with you guys at all times. It can be a little bit more cumbersome to have that. So this was designed as an alternative at this age, and that was actually approved in May of 2019. Valtoco, kind of the same logic. You know, Valtoco is actually diazepam, so it's the same medication that's in Diastat. This was actually approved for children 6 years and older, and this actually does have different dosages as well. So the Nasalam just has the 1 dosage, and that's again just based because with the assumption that everyone is essentially more or less adult size. The Valtoco is again kind of can be adjusted a little bit because we do have some changes in terms of weight and age as well. So at 6 years or older, this is a potential option as well. And sometimes with the Valtoco, the instructions may be to give both sprays at one time, 1 in each nostril. And again, that is just calculating the weight based on their size as well. The Nasalam, it's 1 spray weight. If you need a second spray, then you do the other nostril. So it's much more like the Diastat. You always have 2 copies. Depending on the patient with the Valtoco, you might have to give both sprays at one time. So that's again just something to take note of. And that was really just improved over 2020. In terms of giving the medication, it's relatively straightforward. It's very similar to a lot of our nasal sprays we use for like allergy medications. And the side effect profiles, aside from the same side effects we might have from Diastat or other benzodiazepine medications, you might get some side effects like what you would with the nasal spray. Kids may, if they are somewhat conscious at that time, they might be able to feel it kind of going in their nose. There might be some burning and things like that as well. But the process is very similar in the sense that it is just in the nose. You spray. There's the tip that goes in the nose. You can just put your fingers kind of over each end of it, and this is also pre-measured out as well. So it's a one-time thing. You don't prime it. You don't kind of push it a little bit. It's one shot all the way through. Push it all the way through, and you're done with that medication. So moving on to the next stage of status epilepticus, this is kind of getting into the kind of intermediate phase. This is if the class of the benzodiazepine medications don't work. So kind of in that like 5 or 10 minute mark after you've gotten through the benzodiazepines, whether that's given at home, en route, when they get in the hospital. If those aren't working, this is what we do next. And this is typically our IV anti-epileptic medications. So very classically, phosphonate and phenobarbital are used. That's what we have set aside in our protocol as well. Those are much older medications, very easily available, at least in terms of different formulations of that. We don't just hold you guys to those strictly, though. This is kind of a spot where we make a lot of different changes, sometimes just depending on the patient. So for some patients, they may be on a medication that may be able to be given IV, and we might give them that medication rather than giving a different medication. So that might be a change that you may see. So I just listed some other common medications that might be used other places, as well as some changes that we might have as well. So Keppra, levetiracetam, Depakote, lacosamide, or Vimpat, and Briviact, they all have IV formulations available as well, but used less commonly for status epilepticus. And the basic structure is, again, we try to give a dosage once, see if that works. There's some time that will take for that medication to really infuse. And if we're not seeing that response, we might give a little bit more of that same medication. We might move on to the next another medication to see if that medication works. But really, if we're having to give a couple dosages of an IV medication as well, at this point, they've already gotten, 2 doses of a benzodiazepine plus another medication and maybe a 4th medication or a 3rd medication at this point. So moving kind of along, at that point, we are more concerned about having some side effects from getting so many medications. Kids may be, and really from having an ongoing seizure for going on for, at this point, 15, 20 minutes, 10 minutes, 10, 20, 15, 20. We really have to make sure that, we have our emergency personnel available to just check on the patient, make sure that they're breathing okay, make sure that they don't need to be intubated, but definitely this is a time point where you often might see that, a child being intubated or an adult being intubated for a prolonged seizure. And, at that point, things might get a little bit trickier in terms of seeing the seizures, because we sometimes might use medications that might paralyze the patient temporarily just so that they can safely intubate. But throughout this entire time, we do have to reassess, and sometimes there might be, we move on to this next phase kind of evolving. The third phase, you definitely have to do more reassessment of kind of what's going on if your seizures aren't stopping with those anti-epileptic medications as well. So once we've kind of crossed that 20-minute mark, this is kind of like the 3rd phase, where we would use more of our continuous IV medication. So before we were giving kind of a single dosage of a medication, these might be continued for hours, several hours, just to try to make sure that we are really stopping the seizure. As I mentioned, sometimes they are intubated. They're typically intubated at this point once we get to this stage. And as I mentioned, they might also receive medications that might paralyze them. So it's a little bit harder sometimes to know if the seizure is stopped because we've paralyzed the patient or if it's truly stopped. And that's where you might see the child be hooked up to an EEG as well, so a more prolonged EEG, just to make sure that we can, one, make sure the seizures have stopped from the standpoint of the brain and brain activity, and then also sometimes that can be used to just adjust our medications as well. So some of the medications we might increase the infusion just to make sure that the seizures, one, have stopped, and then eventually at some point it will be gradually taken off. So making sure that we don't see seizures come back as we're taking off the medication is also important through this stage as well. And then at the end of any episode of status epilepticus, really, and sometimes even simultaneously through that process, you might see that we really have to think about, is our patient on the best medication regimen to make sure that we can prevent further seizures? So adding maintenance medications or adjusting medications that they're on might happen at really kind of in this stage where we've stopped a seizure, but we want to make sure that we're not having more seizures come on soon after or later. Typically we will, monitor for a period of roughly about 24 hours, at least a day or so. That might vary a little bit based on certain situations, but if we're going on having a seizure lasting for a prolonged period of time, definitely to the point where we're not sure if we're having to hook up to an EEG. We're not sure exactly if the seizure stopped or it took a long time to really get everything to stop and to recover back to normal. Definitely will be monitored longer versus if somebody were to get one of these interventions, the seizure stops and they kind of go back to their normal selves within a few minutes to an hour or so. Different situation, but definitely want to make sure that they are fully back to normal before we even think about kind of sending patients home or keeping them at home. And that is quite variable, and oftentimes your regular neurologist might make some changes to those plans as well. For some situations that might be augmenting those maintenance medications we mentioned. Sometimes just changing that plan around just to make sure that we have things available quickly should they have a prolonged seizure. Just knowing maybe what medications work better for that patient and in the acute time period can also be changes that we talk about after we've gone through status epilepticus. But definitely making sure that we have close follow-up as well. Everybody is informed of the situation that happened so that we all on the same page and we can help prevent seizures moving forward. Just some closing remarks. So I do just want to mention, status epilepticus is very much our emergency situation for seizures, but it can very well be controlled if we kind of think about things in just very systematic processes and we prepare, intervene earlier rather than later, making sure that we know which medications work better. We can, in a lot of situations, we can stop this earlier in that process, and hopefully in that that 5 to 10 time frame would be ideal, because definitely we find that our patients do recover from that a lot quicker. They're less likely to need to be in the hospital setting for a prolonged period of time, and oftentimes they might be able to even stay at home or leave from the emergency room if they can go back to normal relatively quickly. The duration of seizures definitely plays a role into that, and we might see other complications come if seizures go on for a longer period of time. So it is also just very important that we know where kind of intervene, and we have everybody available should things continue. And definitely the intranasal and rectal medications play an important role of really kind of helping us stop seizures sooner rather than later.